speaker is a colleague of mine. Finally, Liesl, we are in the same department. Yes. So Liesl is a senior family physician and senior lecturer at UCT. She did qualify on the other side of the river from where she is now, but actually she works up the west coast at Friedenberg and takes vast numbers of students for very short periods of time. And I don't know how she does it. She's done it for the last how many years? Many years. But she's going to present on some ideas of changing that program and hopefully involving all of us in the discussion as to how it could change. So Liesl, over to you. Thanks.
Steve, and yes, it's really exciting to finally be one department. In UCT, we were formerly a different division for family medicine and primary health care, which was the weirdest concept. So we're very excited to be together because we speak the same language and we've got the same end goal. So now we can finally sort of get out of our silos, which I think is a very big theme in medical education at the moment. So what I want to do is I want to take you guys through the journey of what we have at the moment with regards to our family medicine training, especially for our final year students. We're calling it the 2x2 model, referring to 2 weeks district urban training and 2 weeks then a rural urban training. Yeah, rural, peri-urban, I mean, an hour and a half out of the city with a KFC, 2 Willys Foods nearby. I mean, what is the definition of rural? But 2 KFCs within the area, you know? So it's a relative concept with what is rural, but I mean, it's definitely more rural and a different healthcare system. Yeah, so here on the left-hand side, you'll see some of our students that's rotating through CHC, and then on the right-hand side are some of the students standing in the Namakwaland flowers outside one of my clinics after we had a clinic visit. So why are we talking about a change? So with regards to the UCT curriculum as it is standing at present, I say to you guys that we've got a modular system for the majority of the training. And at present, it is a 3-week city, 1 week rural, but then everybody that's not part of the longitudinal rotation actually rotates through that. But 1 week, as Steve has said, I mean, it is so short. You just get to know people's names and then they go. They don't yet know where to get tubes to take blood. They don't have it's sort of a sightseeing tour almost, and that's not what we want. That's not sufficient exposure. Yet, we know everybody can't go through an LEC kind of system. So when I started there, being at Vredenburg was an elective site, a 4-week rotation, and of those students that actually had the 4-week rotation, so many has returned. So really awesome feedback with regard to that. Some became GPs, some came back for community service years, but you know, they returned. But then we said, but there's a bigger need. We want fit for purpose graduandi, right? And having 4 people per block, 10 blocks of 40 people, therefore rotating through a rural site and not a CHC primarily as a rotation is just not good enough for the doctors that we need to create for South Africa. So then it became a step approach of at least 1 week. Okay, let's go show everybody that you're not going to die if you go there. You know, there is a Willys Foods, there are 2 KFCs. But then we got a bit stuck there. And as much as we are in a curriculum transformation process and things, we haven't grown much. And I think it's important that we do have the discussion to say, yes, we know it's not ideal, but what more can we do in the interim? What more can we provide? And what would be the outcomes that we would like to achieve with rotations like that? So as mentioned, we're busy with the curriculum transformation, whole undergrad curriculum review. But it's the beginning of a process. And how long does it take to get a curriculum, number one, reviewed, number two, implemented? It's not an overnight thing. So do we want to produce for another 5, 6, 7 years people who is not comfortable or not interested in going rural? Is that who we want to graduate? And then based on the student feedback has always been extremely positive with regards to the fact that they felt autonomous, the fact that they had the confidence, exactly like what Francia was saying just now, giving them the responsibility. Suddenly they have to dress up and claim that professionalism. They have to act the role. And we introduce them also as our junior doctors. I don't introduce them as students at all. And they sort of, you see them walking taller, the shoulders a bit back, a bit of uncertainty. You can see those knees knocking every now and then, but they live the role. And again, isn't that the kind of people that we want to create? And then, of course, the CANMET and the HPCSA graduate attributes. We want lifelong scholars. We've been creating students that waiting for us to spoon feed them. Is that folding? Does it go with CPD activities? Does it go for developing your future? Or are you then going to be the kind of person who's just sitting back and waiting for things to happen? Professionalism, good communicators, collaborators, interprofessional, right? And where do you get more spontaneous interprofessional than in a more rural / peri-urban kind of setting? So all that, manager, leaders, and then healthcare advocates for our patients. So UCT has written this aim. We aim to produce generalists, a generalist healthcare professional, capable of providing healthcare in a decentralized health system, imbued in the spirit of inquiry, and above all, committed to the principles of equality and social justice embodied in the primary healthcare approach. Preventative care, why do we need to end up in hospitals like we were hearing yesterday as well? So let's prevent people from getting there. So if I quickly show you guys the UCT footprint. So here we're back in the Western Cape, and this year we are having 234 medical students in the final year class, with the majority of their training have been done in the city of Cape Town. That's it. GSH, level 2 hospitals around, but that's where they've been. This year, we've got 24 students on the longitudinal integrated program here in the Garden Route. Next year, it's going to be 24, so definitely growing. And there is such a need for that. And we hear the wonderful feedback that comes from that. But this is 24 students out of a class of 240. Next year, it's going to be 240 students. Is that enough? Is that enough to say, but this is the kind of doctors that we want to produce? Is that enough people to serve the 60% of district healthcare hospitals that we have around? Is that enough? So the rest of the students are then those that don't come to the Garden Route, who's not lucky enough to come to the Garden Route, let's put it like that, to come to the Garden Route. They then still follow the modular system, which are 4 weeks or 8-week rotations, of which family medicine is then only one of your blocks. And then, as I said, is then 3 weeks in the city and 1 week, but then also now in your CHCs in the city. So now hospital-based, CHC, primary care, palliative care in the community, home visits, a lot of emphasis on that, and then 1 week out on the West Coast. So the West Coast, where I'm specifically based, is here in the Saldanha Bay. So you guys can see that's that upper horn of the peninsula there. And if I tell you guys a little bit about Saldanha, so we've got a population of about 125,000 people. We've got one hospital in the area, and we're a district hospital, and there's no specialists. As is, I'm the only specialist, which is a family physician, and I'm not even there full time. So don't you think that the kind of outcomes that we're going to get from people who's got a question for themselves, whether we're going to treat a patient here, is going to be slightly different? If we've got nurse-led clinics where we don't have doctors, which is the kind of clinics, true primary healthcare clinics, clearly your reasoning is going to be different about the level of care that's going to be provided to patients. So distributive justice, since we've been talking a little bit about that, distributive justice to our students, isn't that something we should be considering as well? So if I give you guys a quick idea, 3 weeks, we said in the metro, and just look at all the facilities that's in the metro. The red are your hospitals, and all the clinics are around there in the green. But imagine how easy it is to refer to somebody else. Imagine how quick it's going to be to get a physio referral in comparison to a monthly outreach to a primary healthcare clinic. So how different are you going to manage your patients in a setting like that? Two, where you hear, and this is us. So Vredenburg Provincial is that red marker that you can see, and those are my other clinics that's around, and they are nurse-led clinics. So we've got 8 primary healthcare clinics, 2 satellite clinics, and 1 mobile clinic that serves this population of roughly 125,000 people. So clearly a different emphasis. But while we're there, we're trying to show them what's the kind of admissions that you're going to have in a district hospital. We know you're going to try and refer up patients. What can you try and sort out yourself? Emergency center, including referrals up, but then also the importance of referrals down and good notes, so that when they're in the city, that they give us good referral notes back. We do surgical skills with them, and then we visit the primary healthcare clinics. So my question to the students are always, why do you think you were banished to Vredenburg for a week? And that's literally the word I use, okay? And then I rolled our eyes like, we didn't think it's that bad. But even if they become an intern next year, and it doesn't matter where, in internship, you're going to be in a bigger hospital, level 2, level 3. I'm going to phone you and I want to refer a patient to you. And you're not necessarily going to understand why I want to refer this patient to you if you don't have an idea of the context where I'm referring the patient from. Do you know that we're only 1 doctor on call for the whole hospital? So we've got 123 beds. Yeah, 123 beds. So what does it mean for the patient who needs to get an hourly blood gas? Can I do that? Clearly, that's not going to happen. What does it mean for my nursing staff, etc.? How many units of blood do I have? I heard yesterday somebody said 20, and I'm like, oh, that could be heaven. It's not the fact. You know, we had 5, we've been upgraded to 8. So if you understand that we would like to send and then rather receive the patient back from you, you know, it's clearly going to influence the advice that you give me and the kind of patient that you're going to accept. So that's for internship. Yes, they come back for and then also for their 6 months family medicine rotation. We get them for 2 months. So definitely it's a bit of preparation for that. And then of course your community service here, where you're typically going to be in a hospital like this. And we've got 4 to 5 community service doctors at any given time. So it's a wonderful opportunity for the students also to network and to hear what has happened in other places, how did they experience it, etc. So yeah, and then you've got to make your decisions about the urgency of patients. I mean, talking about surgical skills, for instance, what is important? To do an appendectomy in your internship? Are you going to do an appendectomy in your internship? No. But isn't it more important to be able to diagnose appendicitis and to know which patient to refer? And so why is the emphasis different in our training? It's the kind of questions that we should be asking. So we've engaged with our stakeholders. It was our division of family medicine, who then also saw the need for this change, which included our community healthcare doctors, community health center doctors, sorry, because obviously it's going to have an impact on them, not having the students there. We all know that students are actually wonderful to see patients, and they see patients in so much depth. So yeah, we consulted with them. It was the Faculty of Health Science, especially the undergraduate committee, and then finance. And these are the guys that we're struggling with at the moment, okay? Department of Health, the Saldanha-based sub-district, who's welcoming us with open arms. So we're very happy. both from the hospital side as well as the primary healthcare side, the Saldanha Bay community, where there was community engagement to see whether they really feel treated well by the students. And they were very welcoming. Hospice, because we want to extend our palliative care as well there. And then our student engagement. We haven't gotten to the student engagement part yet because we don't know when we're going to get money in order to do this. So we don't want to prep the wrong group. We don't want to get the permission from the wrong group. We want to create the excitement and the enthusiasm, but we don't want to prep the wrong group. Okay. So if I talk about the curriculum transformation, just want to give you guys the top 6 things that's actually on the table and what the UCT is deeming important with regards to that. So it's social accountability, decolonization, and then interprofessional education and collaborative practice. Again, what a wonderful opportunity, don't we sort of spontaneously have on our platform? Transformation, student-centeredness, the students said they want to be there longer, so hello. And then professional attributes. We already spoke about the students, claiming their role. So what is the Vredenburg proposal? At the very least, a 2-week rotation. And we know 2 weeks is still far too short. I know, but at the very least, the whole class comes through for 2 weeks. Okay, 1 week more hospital-based. 1 week more primary healthcare community-based with a hybrid learning. So COVID has forced us to do some online lectures, some video recorded sessions, etc. But then also a lot of, because we saved our interactive time for patient care. So keep hybrid learning. With then also hybrid lecturing and student-led learning. So we want the doctors of the CHCs, where they were now for 2 weeks, it still remains the 4-week block, right? To still have a relationship with the students, even though they come to Vredenburg, because they formed that relationship or start building that relationship before they even have been to the CHC, so that you can have more mentoring, more coaching, more role modeling that happens throughout, not just about the academic outcomes, but also about the kind of people that we would like to train. So, yeah, and our CHC doctors are on board with that. And then palliative care throughout the rotation. And with that, we would also adapt our assessment practices with more formative assessments, where we even get the students to peer review each other, for instance, practicing consultations and so on, giving each other feedback. And we know that when there's not a power dynamic, the feedback is easily internalized and they actually reflect on that. Reflective activities as well. And then our summative assessment staying, our patient study, our OSCEs, and then our final facility marks, which then looks at things like professionalism, etc. So for the week at the hospital, the idea is things like minor surgical skills, assisting in theatre, being involved in our ECs. If there's a recess, whether it's a green patient in EC, be directly involved in the team, be engaged so that you actually know where to go get the blood tube after the week, right? Talking about our transfers, and that is really taken at us, being involved with our inpatients, with our interprofessional care as well, and being part of the team of the hospital, literally being the junior colleagues. So getting role modeling, being comfortable in the space, knowing that we can thrive there. We don't just have to survive. And then for the week at the clinic, to go do home visits, both with our health and rehab allied colleagues, but also on our own. Let's go see our palliative care patients at home. Let's go and understand the EML, because the students don't have any concept what's going on in an EML. They do not know what to prescribe and what is available and what's hospital level and what is basic level. And therefore, they struggle with basic prescriptions. They struggle with completing documentation sufficiently. We want to do our ARV services is a decentralized model. So we want them to travel with our HIV doctor to go and see patients in a decentralized platform, not all back at the hospital. And we also would like to then get them engaged in the community to run things like family planning clinics, etc., in the community for the community. And then, of course, palliative care throughout, wherever that is, whether it's hospital or whether that's within a clinic/home visit kind of environment. So, and I'm sort of summing this up. In an interim, we are proposing this, at the very least, a 2-week rotation. But it is not where we want to be. At the end, we do want this longitudinal integrated interprofessional clerkship. That we know is the big dream. And that is really where we're hoping to be going with our curriculum transformation. But the question is, are we really going to wait 7, 8, 9 years to get there before we start exposing larger numbers to a more in-depth exposure on a peri-urban kind of platform? Is that fair? Is that fair to the community of South Africa? And then if this model works, this can be a great model to expand to other district hospitals around, to start launching and again, be filling this interim space. So I would like to end off with what are some of the outcomes and some of the comments that has come from the different stakeholders. So our son here is our Department of Health colleagues and our hospital and clinic facilities. And they were saying continuity of care, understanding the system, referral pathways, it's going to be just so much better. Our outcomes that we have already achieved by having the students, more students exposed to a place like Vredenburg has been returning. On average, we have 2 to 3 of our community service doctors being UCT graduates coming back for the community service year. Just to give you an idea of the environment that Vredenburg is, 2 of this, and I'm only giving you the stats of since I've been there. 2 of our MOs have gone on and specialized in family medicine and are qualified and are in rural. We've got a doctor that's training on palliative care. So, and there's of course diploma in family medicine. There's more diplomas that we're not even aware of. To have come back and formed a GP practice in Vredenburg itself. So it says something, we're doing something right. And then the final feed is just the feedback from the students. They felt their confidence were built. They felt that they needed this for longer. They said all the disciplines were covered and the team, they want to come back. They absolutely loved it. Thank you.
Time for one question. So.
Sorry, did you see students that elected to go to Vredenburg also apply to go to Eden? Do you have any idea if some of them do that? Either or?
Yeah.
Oh, okay.
Yeah.
Yeah, and can I ask another question? Quickly. Do you think you can argue for 2 months?
No. For 2 months. Oh, yes. Longer. Absolutely. I mean, again, we want a 6 months longitudinal integrated rotation. We can do the ops, we can do the surgery, we can do the ortho, we can do the emergency care. I mean, we can do it all.
Why not?
Exactly. But you see, we're waiting for the money. The money. Thank you.
But I think the essential pedagogical dilemma here is the spread versus the depth. So if you're going to reach all 240 students every year, you need a lot of sites and you're restricted in terms of the time, So at the moment, we're able to give 25 to 30 students, lucky students, the longitudinal experience in the Eden district. And the rest get the 1 week and hopefully 2 weeks in the district hospital. but how do we find the happy medium between the two? And what is our minimum level for average Joe student in the standard curriculum? So it's a dilemma. How we resolve that is in part the curriculum transformation process. We need to